as we enter a new year, and amazing that we're in 2025 now, it's a good time to look forward, as well as to bring exciting advances from the previous year or two. And in particular, focusing on the Society of Urologic Oncology meeting and advances in genitourinary oncology and how novel therapies get integrated into the standard of care modalities. And I think about urologic oncology and the use of one of the earliest immunotherapies, the innate immune stimulator, BCG, and how we've come such a long way from innate immune therapies now to adaptive immune therapies, combining immune checkpoint inhibitors with neoadjuvant immunotherapy, the payloads that come along with antibody drug conjugates and the protein engineering of those antibodies that are, after all, in a way, immunotherapies, and they can cause immunogenic cell death. And now having radioisotope labeled antibodies we call theranostics or radiopharmaceuticals, such as so-called Pluvicto, which is lutetium vipavotide tetrazetan. And this radioisotope alpha emitter is a way of giving radiation systemically. And so it allows us to think going forward, how will we integrate what we thought of as local therapies, such as BCG, into earlier or later stages of carcinoma in situ in the bladder, with recurrent and metastatic therapies, which are typically systemic, but now with neoadjuvant approaches in many different tumor types, using preoperative or perioperative systemic therapies, which may actually change the extent of surgery, sometimes destructive surgery, such as cystectomy, and to think of other subspecialty surgical oncologic procedures where we remove an entire organ like the bladder or other organs, and how using systemic therapy to stimulate the immune system in earlier stages of locally advanced disease may allow us to really reorient the role of the surgeon integrating with medical oncology and radiation oncology. And so I think it's a true multidisciplinary approach. It's much more patient-centered, thinking about outcomes and avoiding some of our previous premises that the surgeon was the early stage, upfront, locally advanced doctor, and that recurrent and metastatic disease was only the purview of the medical oncologist, and realizing that we're really integrating how we bring these therapies to bear in a better patient outcome from a therapeutic outcomes and survival, but also a functional standpoint in organ preservation.